unmute Dr. Gobi? Or, sorry. Dr. Johnny, the chairman for the tips in office practice for the house surgeons, Secretary Dr. Gobi, our chairperson for today, Dr. Jijo, and our faculty today, Dr. Bindu Shah, and all our state treasurer, Dr. Ranjit, and all who have joined us on the platform today. Warm evening to each and every one of you. Definitely, we started off with the program in a slow phase, and now we are picking it up by each topic. Last time we had on on immunization, and it was a good crowd puller on that. I think so. This one also pediatric emergency. The idea behind the program is for the house surgeons and also maybe even to fine tune ourselves also on a daily basis, maybe for the house surgeons, especially when they see patients in the casualty or in the ER. So this will definitely be useful for them. And especially when we have faculty like Dr. Bindusha, she's a professor of pediatrics at Government Medical College, Thrissur. Earlier, she was at SAT Trivandrum. So with that vast knowledge, and of course we have a chairperson, Dr. Jijo, who is a respiratory person and also the executive board member of the National Respiratory Chapter. So definitely this will be useful for the house surgeons and everybody who's joined the platform, and even a learning process for all of us. So wishing the program all the best, and Jai AP, Jai Hind. Over to Dr. Gobi. Dr. Gobi, mute.
Madam, can you upload your CV?
Dr. Bindusha, CV.
Hello.
You want me to project my CV?
Yeah,
Madam.
And I think so Dr. Jijo can do the honors.
Yeah. I request Dr. Jijo Joseph, HOD of Pediatric Believers Church Medical College, to introduce our speaker, Dr. Bindusha.
Thank you, Gopi, for that kind introduction. I would like to thank Shimi sir for the opportunity to chair this session. This is a session I'm sure will be helpful for all the interns who are here, because this is something which they regularly see, like sir rightly said, in the ED in different aspects, especially when it comes to children. So I'm sure Madam is a great teacher. Madam is a person who has been part of the SCD team for quite some time. She's kindly the professor of the Department of Pediatrics in Government Medical College, Thrissur. She has written multiple chapters in the PG textbook across the years in 3 editions, the last one being 2022, and the IAP management.
You are muted.
Also, she has been a part of multiple textbooks. She has been the academic editor of the SAT Treatment Protocol for Sick Children and the editor of the Handbook of Pediatrics. She has more than 16 papers in both national and international journals. I would like to pass on the mic to ma'am to continue with the presentation for today, which I'm pretty sure will be useful for the students. We will ask the students to ask any doubts which come to you in the chat box, so that which can be taken up at the end of the presentation. Over to you, ma'am.
Thank you, Dr. Jijo. First of all, before I start, I would like to thank IAP Kerala and the team members for giving me an opportunity to be part of this program. It's always a pleasure to talk with the house surgeons, because they are actually not here to study for the exams or anything. That's mainly for the patient management. So today I'll be sharing some practical tips in the management of respiratory emergencies. I don't want it to be just a lecture. Let us make it an interactive section. You can, whenever I'm asking some questions, I'm actually asking for your opinion, and I would like you to share your opinion through the chat box, so that I will be able to know how you want me to proceed. Okay. So let us start. What is the importance of respiratory emergencies? Respiratory emergencies are the most common pediatric emergencies. Wherever you practice, whether you are sitting in a clinic, whether in a health center, in a hospital, or in a medical college, whether you are working in an emergency room, casualty, or ICU, wherever you are working, the most common cause for pediatric emergency visit is actually respiratory emergency. And majority of these respiratory emergencies, it can be very well treated and the child can be cured if it can be identified early. So if you fail to identify the respiratory emergencies early and initiate treatment appropriately, it may lead on to problems. Otherwise, if you are able to identify early and give appropriate treatment, most of these children can be completely cured. And sometimes other system involvement can also present as respiratory emergency. Before I go into the respiratory emergency proper, I'll just briefly tell you how you assess a sick child. Whenever a sick child is brought to us in the casualty or in the OP, how you assess a sick child. The first thing in the assessment of sick child is the pediatric assessment triangle. This is otherwise known as a doorway assessment. Here we don't have to actually examine the patient. Here, what is our first impression on seeing the patient? That is what is meant by the pediatric assessment triangle. We look at three aspects when you look at the pediatric assessment triangle. First, we look at the appearance of the child. How is the child appear? That is by looking at the tone of the child, how the baby is interacting with the parents or with the doctor, whether the baby is consolable, how is the baby looking, and how, if it is an older child, how is the child speaking. Then we look at the breathing, whether the child is breathing normally, whether the child is having apnea, whether the child is having severe respiratory distress, whether the child is having any gasping respiration or abnormal sounds. We can also look at the color of the child, that is, whether the child is the normal pink color or is having a cyanosed appearance or pale or mottled appearance. So why do you want to look at the initial, look at the pediatric assessment triangle to form an initial assessment? This is only to identify whether our child is having any life-threatening problem. If the child is having any life-threatening problem, the appearance, breathing, or color will be abnormal, and we have to go for an intervention. Before a detailed assessment itself, we will have to do something. Okay, that is the importance of looking at the pediatric assessment triangle. After you do an assessment by your pediatric assessment triangle, we go for the initial assessment, which is an ABCDE assessment, where we look at the airway, breathing, circulation, disability, and exposure. Under the airway, we will see whether the airways are maintainable or if there are any secretions or if it is not maintainable. Under the breathing, here also we will look at the respiratory rate. We will look at the increase in the work of breathing, whether there is an increase in the work of breathing. You will look at the saturations. You can auscultate and see whether there is any decrease in the air entry, any added sounds. Under the circulation, we will look at the pulse rate, volume, whether the peripheries are cold, whether the CFT is prolonged. We can look at the BP also. Under the disability, you will look at the sensorium of the child. You will assess the sensorium mainly by the AVPU score. It is whether the child is alert or whether the child is responding to your verbal stimuli or painful stimuli or unresponsive. We can also look at the pupils in this under disability, and also you can look at the GRBS. Look for hypoglycemia, especially if the child is unresponsive. Then under the exposure, we will look for any rash, any injury, temperature, all those things will come under the exposure. Here, actually, we are actually not going into the complete assessment or anything. I just wanted to just introduce you to this primary assessment. Why? Because in the coming slides, I'll be introducing some scenarios and you can answer the questions whether the patient is having any problem with this ABCD. If the patient is having some respiratory problem in your primary assessment, you will make a physiological assessment only. You are not going to make a diagnosis of the disease by your primary assessment. We are just going to say whether the patient is having any respiratory disease, any respiratory failure, or cardiorespiratory arrest. But at the end of the primary assessment, if you feel that the child is having tachypnea, tachycardia, or retractions, there is an increase in the work of breathing, then you will consider that this child is having severe respiratory distress. If the baby is having severe retractions as evidenced by head nodding and seesaw respirations, if the baby is having bradypnea, the respiratory rate is less, or if there is desaturation as evidenced by your pulse oximetry, then the child is having respiratory failure. And the thing with respiratory failure is that any child with respiratory failure can very fast progress to cardiorespiratory arrest. It tells you that the cardiorespiratory arrest is imminent. It may occur within minutes if you don't take an action there. So, if the patient is having only respiratory distress, even if they have some time for treatment. If the patient is having respiratory failure, you need to act immediately. Otherwise, the child will progress to cardiorespiratory arrest. Okay. So that is how the disease progression occurs. So, and this respiratory distress or failure may be due to different diseases. As I said, even though we are not going, we may not have to go identify the disease by your first initial assessment and primary assessment. We need to know that respiratory distress or failure can be due to involvement of the upper airway, that is upper airway disease. Any disease up to the level of the larynx is considered as an upper airway disease. That can lead on to respiratory disease. Sometimes involvement of the lower airways, like in asthma, can lead on to respiratory distress and failure also. Parenchymal diseases like pneumonia can also present you with respiratory distress or failure. And at the same time, some of the non-respiratory diseases like cardiac failure, if the patient is having a heart disease, cardiac failure, the child will be presenting to you as respiratory distress, but basically the child may be having cardiac failure. Sometimes it may be a child with severe pallor, severe anemia can also present you with respiratory distress. So, respiratory distress or failure may be due to airway diseases, parenchymal diseases, or non-respiratory causes. Okay. Now, we will go on to certain scenarios. Okay. The first one is a 10-month-old baby who was brought to the emergency room. The baby is, and he was brought gasping to the emergency room. On examination, the baby is cyanosed, floppy. There is occasional respiratory efforts only. There is abnormal sound from the throat. Heart rate is only 80 per minute. Peripheral pulses are not palpable. And the mother gives a history that the baby was playing with some beads a few minutes before. Okay, I would like to ask a question. But is this child having any acute life-threatening problem? I would like you to share the answer through the chat box so that I can see. If you feel that this child is having a life-threatening problem, just write, type in Y and send. Don't have to write the whole thing. Okay, very good. You're feeling that this patient is having a life-threatening problem. Why do you think this child is having a life-threatening problem? As we said, by your ABC measurement, we can see that this child is cyanosed. This child is floppy. That means even by your appearance, the child is floppy. And there are only very few occasional respiratory efforts only. Okay. Then what else is by your assessment here? You can also see that the child is okay, the child is having a stridor. There is a biphasic stridor. That tells you that there is some obstruction there in the larynx. The child is also having severe sternal and suprasternal retractions. And by your examination, you are also seeing that there is absent air entry and cyanosis. What is the problem? What is the cause for this severe respiratory distress or severe respiratory failure? What is the cause for this? Here it is due to upper airway obstruction. And here the history is very clear. So since the child was playing with beads, he must have aspirated the foreign body. Okay. So how will you make a diagnosis of upper airway obstruction? That is by the presence of the biphasic stridor and severe retractions, especially in the sternal and suprasternal retractions. In the next case scenario, I will show you a patient with retractions. Okay, and that tells you that there is some obstruction there in the larynx. So from the typical history and an acute onset, very acute onset, there is no prodromal symptoms or anything. The child did not have any fever, respiratory symptoms or anything. Suddenly, this child is developing severe respiratory distress. If it is an older child, there may also be choking spell. Here, what will you do for this respiratory failure? Can you do a bag and mask? Can we do a bag and mask and the child will improve? No, the child will not improve. Why? Because if there is a completely obstructed airway, there will not be any chest rise even if you do a bag and mask ventilation. So what should you do? What should you do? You should actually try to expel the foreign body which is stuck in the throat. For this, you can do this maneuver where you can do 5 back blows and 5 chest thrusts. You will keep the baby in a stabilized position. You will support the whole body with your hand and give the back slaps and chest thrusts till the foreign body is expelled. I'm not going into the details of the procedure or anything. Just give the back slaps and chest thrusts. Okay. And for an older child, if the patient, this is an infant, only for infants you can do this back slaps and chest thrusts. If it is an older child, if the child is able to cough out, you need not do any thrusts. You need to only encourage the child to cough out. The foreign body may be expelled. If the baby or child is not able to cough out, then you will have to do abdominal thrust for older children. If it is a toddler or a 3 or 4-year-old child, you will have to kneel behind the patient and do the abdominal thrust. Here you are not pressing on the chest. You are keeping your fist on the epigastrium, and one fist will be kept on the epigastrium, and you will keep the other hand over that fist, and you are going to press it in such a way that you are applying backward and upward pressure, and the foreign body will be expelled. So always suspect foreign body whenever a child is coming to you with severe acute respiratory distress, especially if associated with stridor. The signs and symptoms may vary depending upon the site at which the foreign body is lodging. But whenever there is an upper airway obstruction, try to dislodge the foreign body if the child is not able to cough out the foreign. Okay. Now we are going to the next patient. Here, this is an 1-year-old boy who was, there is a history of upper respiratory infection and cough for the past 2 days. And the child also had cough, and the mother is telling you that the cough had an unusual sound. There was a brassy or barking type of cough, and he has breathing difficulty and has a harsh sound which is coming from his throat. On examination, the child is lethargic and the respiratory rate is around 60 per minute. The heart rate is 170 per minute. SpO2 is 90% in the room air. Air is decreased. And here you can, I hope you can hear the patient. Can anyone describe what this child is having? You can either unmute and tell me, or you can write in the chat box. What is this baby having? I will play the video once more. Okay. Okay, any answer?
So there's an answer, ALTB.
Okay, okay. Somebody has written as ALTB. So what the child is having inspiratory stridor. You heard the stridor. This is the stridor. And also another thing I would like you to notice is that this child is having what you call mainly suprasternal retractions. When the child is breathing in, you can see that the upper part of the above the sternum is actually moving in. Okay, so the baby is having suprasternal retractions also. Inspiratory stridor with severe suprasternal retractions will tell you that the child is having an upper airway obstruction. Here the child also has cyanosis and also hypoxic cyanosis. The child has decreased air entry also. That tells you that the baby is in respiratory failure, and the cause for this respiratory failure is upper airway obstruction. But when you compare this with the previous child, this disease actually progressed over a few hours. The child had some respiratory symptoms for 1 or 2 days, and this distress actually progressed over a few hours, unlike the previous case. So, as said earlier, this is only an acute laryngotracheal bronchitis, which is otherwise known as croup. And we can grade severity of the croup depending upon the appearance of the child. And croup only, the child will be happy, child will be feeding well and interested in surroundings. There will not be any stridor at rest. That is the importance of stridor, only the presence of stridor at rest. In mild cases of croup, there won't be any stridor when the child is resting. Child will have stridor only when crying or coughing or severe. In moderate cases, the stridor will be there at rest and it will worsen on agitation. There will be some amount of tachypnea, retractions and all, but there won't be any hypoxia. In severe cases, the stridor will be there at rest and there will be marked tachypnea, marked retractions and hypoxia. So from this, we can see that our child is actually having a severe case of croup. So how to manage croup? Here, what you need to give is you need to give oxygen. That is the first thing. Here in croup, you need to keep the baby in whichever position the child baby is comfortable. You don't have to make the baby lie on the cot or anything, because in croup, whenever you make the baby cry, the stridor increases, respiratory distress will increase. So you can hold the baby in whichever position the baby is comfortable. Baby may be held on the mother's shoulder. It means advisable. And oxygen inhalation should be started, but oxygen can be given in the least non-threatening manner. You don't have to just keep anything on the face and force the jet. You may even give a free flow oxygen. Okay. And the thing is that you can give drugs to relieve the obstruction, edema, to laryngeal edema. So to decrease the edema, the best drug that you can give is dexamethasone. Dexamethasone may be given as intramuscular dose or oral dose depending upon the severity of the croup. In the moderate cases of croup, you can give oral dexamethasone tablet. If in a severe case, you can give it as IM injection. A single dose is sufficient. 0.6 milligram per kg, single dose is sufficient. There is no need to repeat the dose because it is a long-acting steroid. So if you give dexamethasone single dose, there will be effect for 2 to 3 days. So you can give this to single dose. And another drug that you can give to decrease the stridor and the airway obstruction is adrenaline. Adrenaline can be given as nebulization, but you need to give a fairly high dose. You need to give 0.5 ml per kg. Then or 3 ml or above, there is no need to dilute the adrenaline. You can give nebulizations with the same adrenaline. And another drug that can be given is budesonide, especially if you're not giving dexamethasone and it's only a moderate case. Only budesonide may be required in some cases. You give 2 milligram of budesonide nebulization. Budesonide is available as respirules, and each respirule will have 0.5 milligram, 500 micrograms in liter. So you need to give nebulization using 4 respirules of budesonide. And in cases of mild croup, actually, you don't have to do much of anything. You may have to give an oral dexamethasone and observe the child. In moderate cases of the croup, you can give IM dexamethasone. You can give nebulized adrenaline also. But after, once you give adrenaline nebulization and dexamethasone, the stridor will decrease. But at the same time, you need to know that sometimes the stridor may reappear on the effect of the adrenaline vein. So you'll have to observe the child in the emergency room for at least 4 hours before you send the patient from the ER if you're using adrenaline nebulization. Okay. And in this patient, this is the patient who is having severe group with respiratory failure. So he needs admission in the ICU and observation. But the management, drug management is essentially the same. You can give dexamethasone and adrenaline nebulization as needed. Okay. Now we will move on to the next case. Here, this is a baby. This is a child who was seen in the clinic by the doctor for vaccination, and the vaccine was given, and the patient was asked to wait in the observation room for 30 minutes after vaccination. And from the observation room, he is rushed back to the casualty around 15 minutes. After the vaccination with breathing difficulty. The baby is not breathing. Baby is having difficulty in breathing. On examination, the child is having a flushed appearance. There is edema of the limbs. There is urticaria also. Here also you are hearing the inspiratory stridor. He has a respiratory rate of 40 per minute, heart rate of 170 per minute, SpO2 of 88% in room air. Air entry is decreased bilaterally. Bilateral bronchi is there and peripheries are cold. Radial pulses are weak. So what is the problem with this child? Is the child having any life-threatening problem? Okay. Is the child having any life-threatening problem? If you feel that the child is having a life-threatening problem, just tell me why. Okay, if this child is having a life-threatening problem, you can see that this child is having the child is having a flushed appearance. There is edema of the lips. That is angioedema and desaturation. That tells you that the child is having a life-threatening problem. So what are the problems here? The child is having actually different problems. The child has an upper airway obstruction as evidenced by inspiratory stridor and decreased air entry, cyanosis. All tells you that there is an upper airway obstruction. Child also has a lower airway obstruction as evidenced by presence of bronchi. Okay, and there is decreased air entry that can also occur even in lower airway obstruction. And the child is also having shock. The child is having weak pulses and cold peripheries as urticaria and angioedema. So, whenever you have a combination of these findings, especially after an exposure to a potential trigger for anaphylaxis, you make a diagnosis of anaphylaxis. Anaphylaxis is a multi-system life-threatening problem. So there is an immediate release of mediators from the mast cells, which will lead on to all these problems. In the respiratory system, there will be upper airway obstruction due to the laryngeal edema, and also lower airway obstruction due to bronchospasm. In the CVS, when child will go into shock. There may be GI symptoms. They may have vomiting, abdominal pain and all. And the skin, you can have rash and angioedema. It's always easy for us to make a diagnosis of anaphylaxis when the child is having skin involvement along with these symptoms. Sometimes skin involvement need not be there in all the patients with anaphylaxis. So skin involvement is there in 70 to 90% of anaphylaxis. So that tells you that around 10 to 30% of children need not have skin involvement. So even without skin involvement, if the child is coming to you with a combination of respiratory, CVS or GI findings, GI symptoms, you need to think about anaphylaxis, especially if it is following an exposure to a potential trigger. Okay. Now, once you make a diagnosis of anaphylaxis, what is the first drug that you're going to give? This I want an answer. Please type in the chat box, or you can even unmute and tell me what is the first drug that you want to give. I will give you choices. Okay. Oh, okay. Everyone is writing. Okay. Then, okay. Okay, I'm very happy. Whoever has written the answer has written it as adrenaline. Okay, that is important because even though we do see patients with anaphylaxis, the number of children who receive adrenaline at the onset of anaphylaxis is less. Because actually my slides are not moving. Let me see. Okay, so the first line treatment is always adrenaline only, and the route of adrenaline should be intramuscular. It's never subcutaneous. Okay, if the patient is having urticaria only, sometimes subcutaneous adrenaline may be effective, but in anaphylaxis there is shock. Whenever there is shock, there will be a decrease in the blood supply to the skin and mucous membrane. So, but whatever adrenaline that you are giving by the subcutaneous route will not be absorbed. So, the route of administration of adrenaline is always intramuscular and in the anterolateral aspect of the thigh. That is the site of injection. What is the dose of adrenaline? It is 0.01 ml per kg, which is equivalent to 0.0501 milligram per kg. 1 milligram contains 1 ml. So there is no difference between ml and milligram. You give 0.01 ml per kg as an intramuscular injection in the anterolateral aspect of the thigh. And if the patient is patient is not better by 5 to 15 minutes, you can repeat it once again. Okay. So the maximum dose for a single dose is 0.5. If you don't know the weight of the child, depending upon the size of the child, you can give. For infants, you give 0.15 ml. For older children, you can give 0.3 ml. For adolescents and adults, you give 0.5 ml. Okay. And use of subcutaneous and inhaled adrenaline is not recommended. So the drug for anaphylaxis is always adrenaline. And along with adrenaline, we have to give other supportive management. As we said, this child is having hypoxia. So we need to give oxygen through the non-rebreathing mask. Where this child is having shock, is having hypotension. So you need to give intravenous bolus. We need to give 20 ml per kg normal saline. And if it is a trigger which can be removed, like a bee sting, bees usually leaves behind the stinger. That has to be removed. And you need to position the patient properly. The patient should not be in the standing posture. The best position is to make the patient lie down and elevate the limbs. If it is a baby and the baby is held on the mother's lap also, baby should not be in the erect posture in the mother's lap. Baby should be almost in the lying position. And if the patient is having laryngeal edema, adrenal nebulization may be given. But the thing is that here also the first drug is IM adrenaline only. After that, you may give adrenaline nebulization. Salbutamol may be given for these things. Okay. What is the role? But when you see, majority of the patients who report to the health centers or any health facility with symptoms of anaphylaxis receive 2 drugs. What do they? They receive antihistamines and steroids. So what is the role of antihistamines and steroids? Antihistamines have effect only on the cutaneous symptoms. It will have some effect on the urticaria, but it will not have any effect on your upper airway obstruction, lower airway obstruction, or shock. So antihistamine is not the drug that you have to give. There is no harm in giving antihistamine, but the thing is that you have to give adrenaline. So after you give adrenaline, there is no harm in giving antihistamine. But if you straight away go and give an injection Avil and hydrocortisone, the patient will not respond. Okay. So, and what is the role of steroids? Steroids have role only in the prevention of the late phase reaction. So whenever there is a acute immune reaction, type 1 hypersensitivity reaction, there is an immediate phase due to the release of the preformed mediators like histamine, and there is a late phase where there are new mediators which are formed and released. And when you give steroid, it will prevent the late phase reaction. So there won't be any change in the patient position just by giving steroids in the acute phase. Okay. And any patient with anaphylaxis should be observed in the emergency room or in the ICU, depending upon the severity of the symptoms. Why? Because the child may have delayed symptoms. Delayed symptoms may be due to delayed absorption from the gut if it is an ingested allergen, or it may be due to the biphasic reaction. And whenever the patient has severe initial presentation of anaphylaxis, require more than 1 dose of adrenaline, or whenever there is a delay in getting adrenaline, there is an increased risk of biphasic reaction. So all these children should be prescribed steroids and has to be observed in the emergency room or ICU. And whenever a patient is coming to you with anaphylaxis, it's very important that we need to tell them how to prevent further episodes of anaphylaxis, because each and every episode of anaphylaxis is potentially fatal. If we need to help the patient identify the allergen. Sometimes allergy, in this case, the allergen is very obvious because it occurred after vaccination. Sometimes the allergen may not be very obvious, may be that parents may have some difficulty in identifying the allergen. So we can help in identifying the allergen and try to do an allergen avoidance. And it's always better that if we can provide the patient with an adrenaline auto-injector EpiPen, but it's actually not freely available and it is very costly also. And it has a very short half-life. Short shelf time. It will be the expiry period is very less. So that most of our patients will not be able to afford the EpiPen. There what you can do is to give them a pre-filled syringe with adrenaline. You can use a insulin syringe and load it with the required dose of adrenaline. And the thing is that you need to replace the insulin needle. Insulin needle is actually designed for giving only subcutaneous injection. So you need to replace it with a longer needle for IM injection. And this can be kept in a spectacle box because adrenaline is photosensitive. So it has to be kept in a box and can be given. This is one of our patients for whom our PG gave this adrenaline injection by giving an adrenaline pre-filled syringe. You can ask them to make another syringe after 3 months. That we can do. This is something that we will be able to do. Okay, now we are moving on to the next topic. Here, this is an 8-year-old child with a child with history of breathlessness. He has cough, breathlessness, and wheezing from today morning. He was having cough for a few days now, having breathlessness and wheezing from today morning. On examination, he is having an increase in the vocal breathing. There is prolonged respiration. He is able to speak only in words. Respiratory rate is 30 per minute. Heart rate is 160 per minute. SpO2 is 92%. Bilateral rhonchi is there. And there is history of recurrent wheezing. There is prior history of recurrent wheezing. So what is this child having? Is this child having any life-threatening problem? No, right. The child is not having any life-threatening problem. But what is this child having? This child is having respiratory distress or respiratory failure. Here the child is having respiratory distress, right? And since the child is having some amount of hypoxia also, the SpO2 is only 92%, we may even consider it as failure. And what is the problem which lead on to this respiratory distress or failure? That is due to lower airway obstruction. Why? Because this child is having prolonged respiration and rhonchi are there. So it is a lower airway obstruction. From the typical history, you know that this child is having an asthma exacerbation because there is history of prior episodes also. So this is an acute asthma exacerbation. So whenever a child is having acute asthma exacerbation, we need to actually classify and see whether the child is having a mild exacerbation, moderate exacerbation, or severe exacerbation. Why? Because our management varies. In mild exacerbation, child will be having some amount of tachypnea and expiratory rhonchi, but there won't be any increase in the vocal breathing. The child will be able to walk, child will be able to talk in sentence, child will be able to feed and all. There won't be any respiratory distress, only some tachypnea, and there will be presence of rhonchi. In moderate exacerbations are always characterized by increase in the vocal breathing. There will be increase in the vocal breathing and rhonchi will all be there. Then when the child is speaking, the child may be able to speak in phrases only. In severe exacerbation, the child may be agitated, child may be drowsy, child may have hypoxia, diaphoresis, tachycardia, child will be having difficulty in speaking, child will be able to speak only in words or won't be able to speak at all, and the air entry may even be decreased. Sometimes in life-threatening exacerbation, you may even have silent chest in the presence of respiratory distress. The child will be having an increase in the vocal breathing. At the same time, if you are auscultating, there won't be any breath sounds at all. No? That tells you that this is an acute life-threatening episode. Okay. Here the child is not having a life-threatening episode. The child is having, since the child is having hypoxia, we can consider that this child is having a severe asthma exacerbation. Okay. How to treat asthma exacerbation? Asthma is the mainstay in the management of asthma exacerbation is short-acting beta agonist, that is salbutamol. But along with that, you have to start on oxygen inhalation. This study is having a SpO2 of only 92%. So you start straight away, start on oxygen inhalation and start with nebulization with salbutamol. What is the dose of salbutamol that you use for nebulization? That depends. Usually for all drugs, we use the milligram per kg or microgram per kg to calculate the dose. But there is no need for you to calculate the milligram per kg in case of salbutamol nebulization. For an older child, that is above 6 years, you use 1 ml of nebulizing solution. And for a younger child, less than 6 years, you use 0.5 ml of nebulizing solution. 1 ml of salbutamol nebulizing solution will contain 5 milligram of salbutamol and 0.5 ml will contain 2.5 milligram. There is another preparation of salbutamol which is available as respules. Respules are ready-made preparations for nebulization. If you are using the nebulizing solution, you will have to add saline and make it up to a volume of 3 to 4 ml. The usual capacity of the nebulizing chamber is 3 to 5 ml. So, minimum quantity to be taken in the usual nebulizing chamber will be 3 ml. So, if you are taking 1 ml of salbutamol respiratory solution, nebulizing solution, you will have to add at least 2 ml, 2 or 3 ml of saline and make it up to 3 to 4 ml. But if you're taking Respiratory, there is no need for you to dilute it. It's already in a form where it is ready to be nebulized. You just have to keep it in the nebulizing chamber and start nebulization. So you need to start oxygen inhalation and nebulization. Since this child is having a severe exacerbation, you need to give 3 times nebulization back to back. Okay. And for a mild exacerbation of asthma, you don't have to actually go for nebulization for each and every child. For a mild exacerbation of asthma, use of MDI with spacer is as equivalent as or even better than nebulization. So, but for moderate exacerbation and severe exacerbation, you may have to go for nebulization itself. Another thing is that you need to know is that whenever you are giving nebulization for a child with moderate or severe exacerbation of asthma, always give oxygen along with salbutamol nebulization. Why? Because salbutamol will actually increase the ventilation perfusion mismatch. Usually in our body, whenever all the alveoli are not ventilated at the same time. When there are alveoli which are not ventilated and which are ventilated. You can see that whenever a ventilation to a particular alveoli decreases, our body will decrease, there will be a local vasoconstriction of the arteriole which supplies that alveoli, so that whenever ventilation decreases, the perfusion also naturally decreases. But when you nebulize with salbutamol, what will happen is that salbutamol will actually abolish this constriction, so that salbutamol will increase the perfusion to the non-ventilated alveoli, so that there will be ventilation perfusion mismatch which will add on to the hypoxia. So whenever we are nebulizing a patient with moderate or severe exacerbation, always make sure that the patient is getting oxygen along with salbutamol. And in the case of severe exacerbation, we can even go in for an oxygen-driven nebulization. Here, you're not going to use the nebulizer machine. You're going to connect these oxygen tubings directly to the oxygen flow meter, and you're going to nebulize just by the pressure of this oxygen. So for severe exacerbation, it's always better that you go for this oxygen-driven nebulization. Okay. And the other drug that is needed for asthma exacerbation is systemic steroid. Among the systemic steroids, we prefer to give oral steroids in almost all cases. IV steroids are given only for severe exacerbation and also any child who is not able to take orally. In those conditions, you can give IV steroids. Otherwise, any child with moderate exacerbation will require oral steroids. For mild exacerbation, there is no need for us to start on oral steroid for all patients. For moderate exacerbation. Any child with asthma exacerbation where there is an increase in the work of breathing, we need to start oral steroids. And the second indication is a failure to respond to reliever or increase in the controller within 2 to 3 days. Whenever the patient is having symptoms, we will always ask them to take reliever drugs and also increase the controller drugs. If by increasing the controller drugs and taking reliever drugs, if the patient is not having symptom relief by 2 or 3 days, we have to start them on oral steroids. Then any child with history of sudden severe exacerbation and any child with risk factor for asthma-related death should receive oral steroids even for mild exacerbation. But these two group of children, history of sudden severe exacerbation, they are otherwise known as brittle asthmatic. They will actually fail to perceive the initial symptoms so that they will be coming to you with only even sudden severe exacerbation. And those children with the risk factors for asthma-related death, they have to be started steroids even at the beginning of an exacerbation. Even and for a mild exacerbation, they will require steroids. And these children, even if they are coming to your observation room or casualty with mild exacerbation, they also need to be observed in the casualty. You should not send them back. For children, usually children with mild exacerbation will improve with just a dose of nebulization and we can send them back. But if a child with mild exacerbation is having either a history of sudden severe exacerbation or risk factors for asthma-related death, they have to be observed in the observation room and also they have to be started on systemic steroids. So which are these risk factors for asthma-related deaths? Any history of near fatal asthma, any history of intubation for asthma, then hospitalization on ER visit due to asthma in the past year. If the patient is currently on oral steroids now and the child is presenting to you with an exacerbation, if the patient is not using inhaled corticosteroids, if the patient is not compliant with the inhaled corticosteroids, then if the patient is excessively using short-acting beta agonists, the baby child is finishing 1 canister per month, that child has an increased risk of asthma-related death. That tells you that the child's symptoms are uncontrolled. If there is food allergy in a child with asthma and presence of comorbidities, psychiatric disease, all these are risk factors for asthma-related death. As I said earlier, any child who has risk factor for asthma-related death need to be started on oral steroids early and has to be observed. They should not be sent back home. Okay. What are the other drugs other than the steroids? Then another drug that can be given for bronchodilation is nebulized ipratropium. Dose is also depending upon the age. Above 6 years, you give 250 microgram and less than 6 years, you give 125 microgram. Steroids, what are the doses of steroids? Prednisolone is the usual one. 1 to 2 milligram per kg prednisolone can be given for 3 to 5 days. Or you can even give dexamethasone. If you're giving dexamethasone, you need to give only shorter duration. You can give for 1 or 2 days only. In severe exacerbation, we give go for IV steroids, either IV hydrocortisone or methylprednisolone. And if the patient is not improving with nebulizations and pure steroids, the patient has to be admitted and go for the next level of management, including IV max self-turbitanol. We are actually not going into that. And whenever you send the patient home, any patient with asthma coming to us with exacerbation, we need to start them on asthma preventive therapy, start on inhaled corticosteroids, give shorter course and give a date for follow-up. Okay. Now we are going on to the next patient. This is a 2-month-old baby with history of fever and cough for 3 days. The child is also having breathing difficulty for 1 day. Baby is not feeding well. Baby is lethargic. On examination, baby is drowsy with severe respiratory distress, cyanosed, airway clear, respiratory rate is 66 per minute, chest retractions are there, SpO2 is early 80, bilaterally air entry is decreased, crepitations are there, pulse rate is 180 per minute, periphery is warm with bounding pulses. We can also see this child. Okay, you can see that the baby is having tachypnea, very fast breathing, and also baby is having lower chest retractions. You can see that the lower chest is actually moving in during inspiration. So this is a child with respiratory failure. As we said, the child is having hypoxia also, and severe retractions are there. So the baby is in respiratory failure. And what is the cause for this respiratory failure? This is actually life-threatening disease that we did not say, right? The baby is having drowsiness and cyanosis. So the baby is in life-threatening disease and respiratory failure. Here, what is the cause for this respiratory failure? The airway is clear. There is no airway obstruction. There is an increased work of breathing. There is hypoxia. There is tachypnea. There is reduced air entry and palpitation. So, baby is having a respiratory failure due to parenchymal disease. The child is having a severe pneumonia. So, how to treat a child with severe pneumonia? The question is how to give oxygen for a child with severe pneumonia. Here, you know that this child is having severe respiratory failure with hypoxia. The SpO2 is only 88%. So the first thing that you need to do is to increase the oxygen saturation, because if the hypoxia is going to persist, the child will go into cardiorespiratory failure. So you have to give oxygen, give the maximum concentration of oxygen. And this is a device by which you can give the maximum concentration of oxygen. This is known as a non-rebreathing mask. Non-rebreathing mask, you can see that there is a bag there. There is a reservoir bag which is attached to the mask. And there are valves. You can see the valves on the expiratory port. These will prevent the rebreathing of the air, and you'll be able to provide 90 to 100% FiO2 if you are able to attach it very properly to the face. And always make sure that the bag is inflated whenever you attach the NRM to the baby's face, and the oxygen flow rate should be 10 to 15 liters per minute. So our aim is to address the severe hypoxia. Okay, and NRM may not, and here this patient, as we said, is having severe respiratory distress and respiratory failure. This child may require, for stepping up of supportive ventilatory treatment, may require a non-invasive ventilation or even an intubation. But it will always take time for us to mobilize these instruments and start on NIV or ventilator. So the definitive oxygen therapy is by NIV or ventilation. But to get some time for us to mobilize these instruments, you need to start them on 100% oxygen using a non-rebreathing mask. And along with that, you start on parenteral antibiotics also. And the parenteral antibiotics for pneumonia, usually we can start on ampicillin or cefuroxime. The second line drug is third generation cephalosporin. WHO says that for first line antibiotic is ampicillin plus gentamicin, and second line is ceftriaxone. We can follow that. And any child who is not fully immunized or any child who is having life-threatening infection, it is always better that you go for the second-line antibiotic, that is third generation cephalosporin, especially ceftriaxone may be the better choice for a not fully immunized or a child with a life-threatening disease. And if you're suspecting a staphylococcal pneumonia, you need to give anti-staphylococcal drugs like cloxazillin, vancomycin, amoxiclavir, and niclosamide. That we will decide depending upon the chance of our patient having staphylococcal infection. Okay. Now we are going to the last case. This is a 5-year-old child who is brought at 4 a.m. with breathing difficulty to the casualty. The child was sleeping on the floor with the mother, and he got up at the night with pain in the right forearm. And the child went back to sleep and got up after half an hour with abdominal pain and vomiting. After that, he had some difficulty in swallowing tea, which was offered by the mother. Then the child became lethargic. Child was not able to walk. Child had to be carried to the hospital, and there was some difficulty in breathing also there. But on arrival at our casualty, we are seeing that the patient has a respiratory rate of only 10 per minute. Child is having labored breathing. There are some secretions in the throat. Saturation is normal. Patient is on nasal prong. Saturation is 95%. Pulse rate is 100 per minute. Good one. The scenario that I am telling you is actually what happened in real time. We had a patient in the similar history who was brought to the casualty with this. So what is this child having? Is this child having a life-threatening problem? You can type in the chat box. Is the child having a life-threatening problem? Child has life-threatening problem. Why? Because the child has very labored breathing and there is bradypnea, respiratory rate is only 100 per minute. But at the same time, you can see that the saturation is maintained with just with nostril prong, the saturation is maintained. Why? That is because this child is having a ventilation problem. Child is not breathing. There are secretions and also there is respiratory muscle weakness. This is a child who was bitten by a poisonous snake. That is why the child got up at the night, but nobody noticed that there was a snake bite. And after that, all the symptoms that I have described is the classical progression of a neurotoxic snake bite envenomation. Okay, so now the child is in respiratory failure. The child is actually having ventilator failure. Okay, the thing that I ventilatory failure because the child is not breathing at all. Here, what I wanted to tell you that giving oxygen to this patient is not effective, because there is no problem with the oxygenation. Here, what the child requires is ventilation. Just by giving oxygen, even if you give oxygen and make the saturation correct, that is not sufficient because there will be carbon dioxide retention. So the child is actually having type 2 respiratory failure. So this child requires bag and mask ventilation. If you have a normal bag, start him on bag and mask ventilation. Otherwise, this child will progress to cardiorespiratory arrest. And if you have facility for intubation, then go ahead and intubate. But if there is no facility for intubation, another option that we can do is to put in a laryngeal mask airway. This is a simple instrument which can be inserted by anyone. You just need to have one training how to insert the LMA, and you need to have different sizes of LMA. And if you are able to insert LMA and tape the LMA to the face, then you can continue the bag and mask ventilation even if you are transporting the child. You'll be able to continue the bag ventilation, not the mask. When after putting an LMA. By using the ambu bag and mask, you won't be able to transport. The patient has to be kept in your OR, then you will have to keep on bagging the child. If you put in an LMA, then you can connect it to the ambu bag and continue to bag and transport the patient while you have ventilator facility and anti-snake venom. Okay, so that is also important. In ventilatory failure, you need to provide ventilation. The oxygenation alone is not sufficient. Okay, so that has actually completed my topic. So what did we study in this class? We said that if there is any abnormalities in the initial assessment, that tells us that the patient is having a life-threatening disease and you will have to do an immediate resuscitation. Okay. In case of obstructed airway, if you need to suspect foreign body, and if there is foreign body, we have to remove that foreign body. And for croup, the treatment is injection IM dexamethasone and adrenaline nebulization. For anaphylaxis, the drug is IM adrenaline. For non-breathing or bradypnea, you have to start on bag and mask ventilation, secure airway by ET tube or LMA. Lower airway obstruction, if it is asthma, nebulization with salbutamol and steroids. Oxygen-driven nebulization should be given for severe exacerbation. In parenchymal diseases, give oxygen, and in severe hypoxia, use NRM to get time for definitive ventilatory management and start antibiotics. So I am stopping my presentation. If there are any questions, we will discuss the questions.
One question that suppose you have an IV access and an anaphylaxis, we give adrenaline as an IV.
Dr. Gopal, actually, I am not able to hear what you're saying.
I think so. That question was saying if an IV access is there, can we give IV adrenaline in anaphylaxis?
No. For anaphylaxis, the dose is always IM. There is no need for an IV adrenaline. a bolus dose. Give IM. The first dose is IM. The second dose is also SIM. Then, if the child is continuing to have problems, especially the child is having shock, we may start on IV infusion, but that comes only after the first 2 IM doses. There's no need for IV adrenaline in the first, because IV adrenaline we are going to give very small doses as infusion. We need 0.01 ml per kg has to be given IM only. Any role for oral prednisolone in group? Prednisolone can be given, but dexamethasone is more effective than prednisolone. But prednisolone is another drug which can be given. The advantage of dexamethasone is that it can be only a single dose is sufficient. If you are giving prednisolone, you may have to give for 3 to 5 days.
I think so, Dr. Bindusha. I think so. It was a very crisp presentation, to the point, and I think so. You covered all the areas regarding respiratory, starting from the ER, how you do an initial assessment, the triage, and also how you go about dealing with the different cases. I think so. It was a nice presentation, very somewhere even thought provoking, like especially the questions that came up regarding IV adrenaline, the need for adrenaline. And I think so also the main thing is the last one. I think so always a history. We should always be very a respiratory issue. The child, the first episode, like I think so how you mentioned about the first case regarding a foreign body, this one, that was also so certain things. I think so the history should be very careful, and especially the last case, I think so that we always should have an open mind when you see a case, especially like how you said, when you look at the pulse oximetry. Pulse oximeter shows 95% child is having a labored breathing. Should always think other ways around. There's something going wrong. I think so. That was a very crisp presentation. I think so that is definitely very useful for all the house surgeons, and I think so even for a practicing pediatrician also, it is useful when he gets calls in the night from from his casualty officer saying such things, like when he puts up the presentation over phone. I think so these are things also maybe we also should have a thing updating on. So thank you for that presentation. I think so, Dr. Gobi. I think Dr. Gobi's
Thank you,
connections
sir.
are. So I think so that was a nice presentation. Thank you, Dr. Bindusha, and I should also thank everybody who had taken part in. We had a good attendance, so I think so definitely these kind of topics are useful for the house surgeons and even for a practicing clinician. Thank you very much, Dr. Bindusha. And I think so we can call it a day. I think Dr. Johnny is there. I think so, Dr. Johnny, you can put in a word. We are still open for questions if anybody has it. I think so we can close then. Thank you, Dr. Bindusha, once again. Dr. Johnny,
thank you, sir. Thank you. ഇല്ല ഒന്നുമില്ല സർ.
ജിജു.
Thank you all.
Sir, only to add, ma'am has covered everything. One is, ma'am, sir, for the students, when you don't have a cause, always think of also a presentation which can present with a similar presentation. Also a foreign body. These are two things which they do encounter in the ED. Rest everything has been very well covered by madam.
Yes, definitely.
Thank you.
We had a very good attendance also, madam, above 80. It was a very good presentation. It's very important and helpful for the interns also. So thank you, Shimi and Johnny also, and we'll continue with this tips in next month. Thank you everyone who have attended this program. Good night. And Jijo
Good night.
also, good presentation. Good introduction. Okay, thank you.
Thank you. Good night.
Okay, thank you. Thank you, Dr.